Welcome to the Hormone Optimizing Warrior MD, the How MD podcast, your reliable and trusted source for information on hormone therapy for menopause and beyond, and on how to advance into the second half of your life with confidence and optimism, knowing your hormones are optimized in alignment and balance with everything else in your body. Whether it is hormone therapy, peptide therapy, laser therapy, or some other new technology applicable to maintaining our vitality, mental and physical strength, you will hear all about it in this podcast. And you will also hear how to implement the facts and information presented so that you can take action and optimize your hormones and optimize your body. Hello there. I'm continuing this week on the topic of heart disease in menopause. And heart disease is something I have spoken about in the past few episodes, more so in plenty of other episodes I released last year in 2025. The purpose of today's episode is to raise awareness of what would be another optimal surveillance, very important biological marker or test that would indicate dysfunction in a woman's cardiovascular system and the health of her heart outside of cholesterol, which everyone thinks of immediately, right? So I would like to talk to you about the calcium score. The calcium score has nothing to do with your calcium level. It is an actual imaging test. It's a CT, a computerized tomography. It's a low-dose radiation CT of your heart, which is measuring the amount of calcified plaque existent in your heart arteries. And it is true that the calcified plaque is stable. It's not that dangerous. And the gold standard for plaque, for meaningful, dangerous plaque, which is soft plaque, would be a coronary angiogram. Now that is using contrast. It's not very often performed unless a cardiologist recommends it. It's much more invasive than a calcium score. So I'd like to continue the discussion and say a few words about the difference between the hard calcified plaque and the soft plaque, which I touched upon in the last episode. So a little recap for you. The calcified plaque is stable. It's not dangerous, but it is a sign of dysfunction. And if your calcium score is not 0, it means you have plaque and atherosclerosis in your heart vessels. The soft plaque is the dangerous kind of plaque, which can break away in small pieces and then plug up the downstream remainder of the blood vessel that's impacted by plaque. It can happen in your heart, it can happen in your brain, which will cause either a heart attack or a stroke. I'd like to illustrate the importance of interpreting the calcium score by discussing two very, let's call it different or extreme circumstances. And they both, interestingly enough, are men. And I'll tell you more about why I'm giving you men examples, even though I treat probably 90% or more of my patient population is actually women, in a few minutes. So I have the privilege of treating both men for hormone therapy, specifically testosterone therapy. And my first case that I'd like to share with you is a very young gentleman in his 50s who did the calcium score at my recommendation to find out that the calcium score came back with a very reassuring finding of 8. So it's like barely above 0. I think it was 8 or 18. I'm not sure. Either or, this is a very, very low and reassuring calcium score. Obviously, the higher the calcium score, the higher the risk for a heart attack. Everything, though, has to be interpreted in the context for other risk factors. As, guess what? This gentleman with a calcium score of 8 or 18 had a heart attack not too long ago after his test, actually within 12 months. Now, here's the thing. He also drank alcohol quite regularly, even though he modified his risk factor profile significantly after his heart attack. And he had a very stressful job, which apparently I think he enjoyed too much, even though it was very stressful, to give up. I also have the privilege of taking care of a very lively, very humorous gentleman from England. We banter all the time when he comes in. Now, he has a worsening calcium score, and it has worsened over time. I've taken care of him for over 8 years. it is now over 500. This gentleman is approaching 70, a little older than the 50-year-old who had a heart attack. Now, this English gentleman never had a heart attack. Now, he does not drink. He eats a very healthy diet. He exercises regularly, and he is almost retired, so minimal to no stress. And he has a very positive outlook on life. And I'm presenting you with these two numbers, these two extreme cases, for you to get the message that the calcium score will provide very valuable information, but this information needs to be taken in context of other general health issues, in the context of hormone balance, lifestyle factors, which are very, very important when it comes to your heart health, especially stress, sleep, diet, and exercise. These 4 things are the 4 pillars, highly modifiable and highly actionable by you, the patient, the human being who is at risk. And any intervention in these 4 very specific risk factors will decrease or eliminate your risk of heart disease or of a significant heart event or stroke. Now, I don't need to talk about what high stress, poor sleep, a typical American diet with processed foods or centered around eating out or takeout, or what the lack of exercise and the sedentary lifestyle will do to your heart and cardiovascular system. You can imagine. And talking about these 4 things, sleep, stress, diet, exercise, should be part of every appointment all doctors have with every patient when it comes to heart disease assessment risk, except we don't have time for that, almost like always. And this is not the topic of today's podcast, so I'm going to stay on point and continue the conversation on the topic of heart health testing and calcium score. I use the example of these 2 very different gentlemen, one with lots of stress and not great lifestyle, but a very low score and an unfortunate heart attack, and the other with great lifestyle, a very high calcium score, and so far no heart attack and almost 20 years senior. To make the point of how critical these lifestyle factors are in determining your ultimate risk of heart attack. It is about the big picture, not just the calcium score number and not just the cholesterol number. So numbers are numbers. And I promised I'm going to tell you why I used the case of these 2 gentlemen to illustrate the importance of interpreting calcium score within context and not women, because for some reason, the calcium score is not considered for women when it comes to evaluating their heart attack risk. The majority of women, if not all women, are simply started on a statin when their cholesterol is high, and a calcium score test is not even recommended. So very few women have calcium scores. Now, I personally do believe every woman should have a calcium score at age 50. And if it's 0, consider repeating it in 5 years, maybe even sooner, if she chooses not to do hormone therapy. Why this distinction? Well, because it's a big difference between women who choose hormone therapy and those who decide against hormones, in the sense that women who are using hormone therapy will be getting much closer surveillance, hopefully much better surveillance, as long as their physicians are properly trained and prepared to address all the issues that come with managing hormone therapy, as part of the hormone therapy being a multi-pronged tool focused on ultimately the longevity of the patient. So we want our patients healthy and alive, right? No matter what we do for them. Calcium score is a very valuable screening tool, which unfortunately is rarely used by physicians when it comes to women. And I'm hoping that in the future, this will change as more and more awareness on the topic of heart health in women after menopause is, and hopefully will become center stage for any primary care physician or hormone therapy management physician caring for women over the age of 50. Now, calcium score is not necessarily considered a routine screening test that your PPO or HMO insurance or even Medicare would like to cover, and that is a shame. I would like to highlight the steps for the process of getting the calcium score approved so we can make it simple. But you need to know this because this is where the process gets stuck. The woman or the man comes in, there's a conversation between the physician and the patient. The physician identifies the risk factors which justify the necessity of ordering the calcium score. There's the discussion with the patient. Hey, this is what the calcium score is, and I think you should have it. And then an order is provided to the patient with instructions to schedule it with the nearest imaging center, which is performing calcium scores. Now, here's the unfortunate circumstance. This is followed by a lot of back and forth between the imaging center, the doctor, and the insurance company, and between the imaging center and the patient, who unfortunately cannot schedule the calcium score until insurance approves it. Sometimes the doctor doesn't even find out until months later when the patient shows up, says, well, I haven't been able to do the test because of all the back and forth and because the insurance did not approve it. Sometimes there is a little delay around the physician's office as well. We are guilty as charged because the imaging center requires the doctor's note, and that should be easy, right? Just have the staff send the doctor's note. However, if the physician has decided to sacrifice documentation for later, spending more time with the patient, which many physicians do, there will be a delay in finalizing the note. And maybe the message doesn't get to the physician, hey, doc, you got to finish your note. So that's another delay. Now, even if all of these steps are done the right way, the insurance might come back, and it does come back in the majority of circumstances, saying we're not approving the calcium score. Now, even in that case, we can take further steps. It might require an appeal on the side of the patient who needs to complain that the test is justified, file an appeal with the insurance company about why this test, inquiring why this test is not approved when the doctor recommended it. And when, hello, I'm a woman over 50 at risk for heart disease, and heart disease is my primary cause of death in my category of age, right? Sometimes the insurance yields and approves it after the patients appeal it. Now, sometimes it unfortunately, the appeal holds and it requires a peer-to-peer conversation. That means a physician employed by the insurance company as a consultant will get on the phone with the physician who ordered the calcium score, and they have to have a conversation about whether this type of testing is appropriate for the patient and why, followed by a decision. And most of these are no-brainers. The consulting physician that works for the PPO agrees and says, yep, you're right, let's approve it. Now, you can see how the steps in this absolutely insane multi-layer built bureaucracy by the PPO or HMO is simply done in order to deny an expense which they would like to avoid. I have revealed the steps you need to take to get this test approved. Whenever your imaging center says you need the doctor's notes to submit the authorization, contact the doctor's office, let them know your order's on hold until the doctor finishes the note, and the message should be provided to the doctor that day, no later than the next day, and hopefully he or she would be able to finalize the note within a matter of a few days. Once that's done and the PPO does not approve it, appeal it. And if that's also done and denied, then you can request for your doctor to have a peer-to-peer conversation and explain why this test is necessary and should be covered. Now, you've done all of this, insurance denies it. Don't worry, this test is not as expensive as you might believe. At the imaging center near us who performs it, the calcium score, it's $350 cash, no hassle, no paperwork, no delay, no approvals. You call it, you tell them your cash, you schedule it, you pay when you arrive, you have the test, and a week later you meet and discuss the results with your doctor. Now, there are many reasons why the calcium score is not considered a standard screening tool that should be employed routinely for evaluating heart health in women over the age of 50. One of the major ones, it is not considered cost effective. I mean, the mind boggles why it wouldn't be cost effective. But basically, if women over the age of 50 would all have a calcium score every year, apparently the number of lives that would be saved is not worth the cost your insurance plan would have to bear. Of course, there's always concern about the possibility of overdiagnosis or overtreatment for calcified plaque and heart disease, which might never endanger the woman. But overdiagnosis is a serious risk I talked about in the previous episodes when I discussed mammogram screening. It does not seem to slow down anyone from ordering routine mammograms for all women, no matter what age they are. And here are some numbers to illustrate the stark, ignored reality of what actually kills women after the age of 50. It is estimated that there are 200,000 deaths every year in women over age 50 due to heart disease, whereas only 40,000 deaths every year happen in women over 50 due to breast cancer. There is no bigger fuss than the one done around screening for breast cancer to save lives as is being done around getting your annual mammogram. But 5 times more women die of heart disease. You don't see or hear anyone making any noise or fussing over screening for heart disease. The value of a screening test is always to identify women at risk. Obviously, someone with a calcium score of 0 would not require another calcium score for a few years, probably 5 years, unless she has other risk factors which put her in a higher risk category. She's sedentary, she's obese, she's got blood pressure, she's got diabetes, and she's entering menopause. Hello, I would check the calcium score in 2 years. But an initial calcium score screen showing any kind of plaque should prompt an intervention in all the risk factors for heart disease in that specific woman. And that would look like a very different conversation between her and her physician. And once we identify the risk factors that could impact the risk of dying from heart disease, and we address them, she starts exercising, she loses weight, we make a plan about the weight loss, she finally commits and does the weight loss peptides, we control the blood pressure, she starts changing her diet, she addresses the stress, she wants to do hormone therapy to improve her sleep, and all of these things are happening. Then I would like to repeat the calcium score in 1 to 2 years to evaluate her if her disease is progressing or is stable now that we got the risk factors under control. Now, this is probably a long conversation around the calcium score. You get the point. I believe it is a very valuable test, not necessarily considered standard of care, nothing close to how people look at cholesterol, but hopefully one day it will. Ask for it, demand it, definitely consider it before a statin is recommended or initiated. Do not accept a statin therapy without knowing what your calcium score shows. The physician who is placing you on a statin should be very clear. Hey, Mrs. X, you have significant risk factors, and we will need to modify your lipid profile to decrease your risk for more plaque with a statin that you will have to take for the rest of your life. Now, why would you commit to using a statin for the rest of your life if your calcium score is 0? I wouldn't, not even if my cholesterol was 300. Now, if my cholesterol was 300 and I was also obese and sedentary and I had diabetes and high blood pressure and I would drink alcohol daily quite a bit, I would smoke and have all these other risk factors, then yes, we would need to do something right away for the cholesterol until we figure out the other risk factors with lifestyle interventions or risk behavior modifications. And once those are implemented and the weight is better and the blood pressure is under control and there's not so much alcohol and the diet has improved and the woman is exercising and the lipid panel comes back looking real good, then we can consider stopping or decreasing the statin therapy, especially if the calcium score remains 0. Let me talk a little bit about plaque and how does it form after menopause, because we've been on the subject of plaque detection and the calcium score. And I talked a lot about plaque and heart disease in women who age after menopause. I spoke before in many circumstances about how estrogen protects a woman's arteries in many ways, primarily by reducing inflammation, which, as I told you in a previous episode, is crucial for plaque formation. I told you how estrogen improves normal functioning of the blood vessel wall lining called endothelium. But most importantly, estrogen protects a woman by favoring a healthy lipid profile. Once a woman loses her estrogen, her total cholesterol can rise by 50 points or more. Her LDL, the bad cholesterol, will also become higher and will go up. And the increase in good cholesterol, unfortunately, does not match the bad cholesterol, may actually go down because she's now eating poorly, drinking more alcohol, and exercising less once she's not sleeping and has hot flashes and her depression sets in. So the loss of estrogen will impact her lipid profile in more than just, hey, no more estrogen equals bad lipid profile. It is well known that blood pressure will increase in menopause, and the loss of estrogen will contribute to the increase of blood pressure. And that's another risk factor for heart disease. The loss of estrogen during menopause and the major deficiency of estrogen for decades after menopause will increase the levels of systemic inflammation and oxidative stress. These two processes will accelerate the plaque formation inside a woman's blood vessels. So if we look at all these changes driven by the loss of estrogen, wouldn't it make sense to consider estrogen therapy during and after menopause as a possible means to prevent heart disease? Well, this was the initial thought in 1990s when the WHI study was started. And interestingly enough, today, the recommendations against estrogen therapy for decreasing heart risk after menopause as a woman ages are based on the WHI study findings showing that estrogen therapy with oral equine synthetic estrogen combined with a synthetic progestin does not reliably prevent heart disease and might increase risk for clotting events, stroke, and heart attack. But common sense dictates that we should address the root cause of heart disease after menopause. We know that the mechanism of plaque formation and heart disease after menopause starts with the loss of estrogen. We need better conversations around hormone therapy for menopause and how it could meaningfully impact the risk of heart disease caused by changes in the lipid panel, changes in the body weight, changes in the blood pressure, all of them driving higher and higher atherosclerotic cardiovascular risk the further away from menopause a woman goes. We know that estrogen favorably influences the lipid profile. We know that balanced, optimized hormone therapy for menopause and after menopause can support a healthy body weight. We know that well-balanced hormone therapy will improve sleep, help manage stress better, and help manage cravings for alcohol, sweet and salty foods, as well as improve motivation for exercise. All of these would contribute to a healthier blood pressure, a better lipid profile, and better inflammation markers, in the end, favorably influencing the risk for heart disease. One study that looked at one type of estrogen cannot condemn and should not condemn all estrogen therapy as bad or too risky for women's hearts as they age. We should focus on addressing the root cause of heart disease after menopause, which is the loss of estrogen and the extraordinary changes happening to the heart and the blood vessels because of the loss of estrogen. When it comes to your heart, estrogen matters. We need to talk more about estrogen, and we need to talk less about how valuable statin therapy is. I hope this message resonated with you, and I hope you found this episode useful. I will end here and meet you in the same place, same time next week. Please be aware I am now on Substack, and if you enjoy reading thought-provoking articles around menopause and hormone therapy, please subscribe to thehormonetherapyadvocate.com. Until we meet again. Thank you for the time and energy you spent listening to my podcast. If this episode or another have caught your attention and delivered valuable information you have not heard anywhere else, and if you feel I have succeeded in my mission to provide the how to stay healthy and age beautifully, please leave me a review. Your opinion matters to me, and any suggestion to improve the podcast will help make it better for you and for others. You can send my staff a message directly by sending an email to receptionist@herahealthcare.info. I look forward to recording my next episode and being in your ear again.